Good afternoon, everyone. Good afternoon. Welcome to the East Chapel Hill Rotary Club Friday meeting. It is August 15th, and we are delighted to have everyone join us today. My name is Linda Sanders, and I am delighted to be today's Sergeant at Arms. We have what is going to be a wonderful program, and we're delighted to have Dr. Wesley Burks join us today and share with us a little bit on his journey, and Jim will be introducing Dr. Burks. May I ask anyone who has brought a guest to stand up with their guest, and if we could get you to introduce your guest. And guest, Nick, please.
Hey y'all, I'm glad to have my wife
Katie. Katie, welcome. We're delighted to have you with us again. Jim.
My guest today, Aubrey, is a future member of the club, back for her second visit. Aubrey Williams, the general manager of WCHL.
Aubrey, welcome. We're delighted to have you back again, and we look forward to having you join our club. Anyone else have a guest? Do we have any visiting Rotarians? No visiting Rotarians. Do we have anyone who is having a birthday or has had a birthday in the month of August? If you'd stand up. Clay, all right. Happy birthday. What day? The 6th. Happy belated birthday. Do we have any announcements that anyone would like to make? Tim, anything on Teacher Supply Store?
I think Felix is going to have
Oh, Felix, okay.
Thank you, Linda.
Cool. So I will move on. So, Chris, may I give you, thank you. Okay, so pine baskets going around, so bare minimum $10 per person today. Is that okay? That might be a little generous. All right. What I do is ask everyone to join me in our invocation. We give thanks for the opportunity to be Rotarians. Rotarians dig wells from which we will never drink. We vaccinate children we will never meet. We restore eyesight for those we will never see. We build housing we will never live in. We educate children we will never know. We plant trees we will never sit under. We feed hungry people regardless of race or politics. We know real happiness, which, as Albert Schweitzer once said, can only be found in helping others. For this opportunity, we give thanks. So for our Sergeant at Arms today, I was thinking about what might be an interesting topic to have. And I thought, maybe some historical highlights on what occurred on August 15th over history. So I just want to share a few of these with you, and some of you might know the answers. What happened on August 15th in 1620. Anybody remember? So the Mayflower set sail from England to the New World. Did someone get that? Guess that? Peggy, well done. Gosh, I wish I had a dripping rag to give you. Well done. Well, do you know what happened in 1877? Edison's first recording. And do you know what he recorded? Mary had a little lamb, marking the first sound recording in history. Now, how he came up with Mary had a little lamb, I probably should have asked ChatGPT that question, but maybe his wife's name was Mary and his lineage were shepherds, I don't know. Then, in 1899, Henry Ford left his job as chief engineer at Edison Illuminating Company to focus on building automobiles. So that was basically planting the seeds of Ford Motor Company. And for those of you who might not have been to Fort Myers and gone to the Ford and Edison museums, they are just fascinating. So if you ever have an opportunity to go there, I'm not hawking and I'm not getting any kind of payments here, but it's wonderfully rich in terms of history and what these two incredible individuals have done. In 1914, the Panama Canal opens. In 1947, India finally broke free from its nearly 200 years of British colonial rule. Then in 1945, the end of World War II in Asia, when Emperor Hirohito, announced Japan's surrender, marking the end of World War II. Now this was kind of interesting. 1965, and I know there were a lot of people in this room who were alive in 1965, and there was an invasion that was taking place in the United States. Who said the Beatles? Oh, all right, yeah. So in 1965, on this day, Stadium Rock was born. And you're going, what is Stadium Rock? The Beatles headlined a concert to nearly 60,000 fans in Shea Stadium, New York. And that was the genesis of Stadium Rock. Now let's fast forward to 2024, the largest stadium concert. Anybody have any guesses on who did that? Taylor Swift. The Melbourne Cricket Ground, 96,000 participants, and over 3 nights, 288,000 people. Now, I would have loved to have seen her cash flow over those 3 days. Then, last but not least, that I'll share with you, because there are a whole bunch that I could continue. In 1998, Apple unveils the iMac. Remember that? They introduced the colorful Mac. Remember the pale blue or aqua and kind of this light apricot. So then to stay with, and I'm rounding out now, I'm just happy that I am. Today is actually National Lemon Meringue Day. So it is a sweet excuse to give your sweetie something sweet this evening. Thank you very much. I will turn it
over to Thank you, Linda. Good afternoon, Rotarians. And as usual, thank you for coming. Now, next week is a big one. Yes, Teacher Supply Store. It's happening next week on the 19th, 20th, and 21st. And Rotarians, this is when we roll up our sleeves, and for some, we roll up our trucks with teacher supplies. Now, you've really done well. Volunteering, signing up for volunteering, donation, offering your trust, you've done very well. We are on track to have a very successful event. We still have some open spots, so if you wish, please sign up. And if you need help, just get in touch with Tim Smith and or myself, and we'll help you out. Now, you know we like mixing fun with our service. And with that, we have a pop-up event at the Dead Mule. And I promise you, no harm happened to the mules. So, please show up, let's fellowship, and tell Chris stories. I was informed by Jeff that our good friend Fred McLaren had a successful surgery, but he had to go back to the hospital. So just keep him in your thoughts. And also, I have some good news. Lida, if you remember last year, Ryder was able to lock in a very good deal for the back night. And again, this year, he was able to replicate that by negotiating hard. So thank you, Lida. And we have a special award presentation by Badua.
Before I do that, Linda Sanders, I have another on this day. Let's see, August 15, 2025. What person among us, instead of going into the men's restroom, went into the women's restroom? And upon leaving the stall, bumped into Linda Sanders. Who among us did that? I did. And she vowed never to tell the crowd. She vowed to keep it a secret, and you did. I didn't know you were going to be sergeant at arms, but I wanted to come out with it right away. I'm here to talk about the awarding of a barometer fellowship, a little bit out of the standard way that we have done these. 4.5 years ago, Patty Hill passed away. And within days after her passing, Earl Chesson came to me and said that he and Margaret wanted to donate $5,000 to the foundation to have a barometer named in her honor. And so soon after that, we scheduled a time when Gary would be here. Patty was married to Gary Hill, longtime member and continuing member of this club and past president, and her son, Gary Hill Jr., was also a member. But we scheduled it, and Gary said to us, well, just emotionally, it wasn't time to do that, and so we waited a while, and we scheduled it another time, and he made the same comment, and so I was with Gary to say, whenever you're comfortable having this done in the traditional way. And his health is not excellent, and he's not coming as much to Rotary, so we wanted to think about another way to do that. And Gary's been part of a long-standing group, over 50 years, playing cards with a group of people, so which includes me. And so I said, Gary, how about if we do it? We were scheduled last Wednesday to go to Squids, because we don't play cards anymore. We just talk and so forth. So he liked that idea, so we invited our spouses as well, and we had Earl and Margaret come. So we had about 10 people there, and in that occasion, we presented to Gary the Ronger Fellowship in honor of Patty. Patty was a faculty member at the UNC School of Nursing. She was immensely involved in this community, served on the Charles House Board of Directors for a number of years. And when you think about the dental mission, we probably did the dental mission 15 times. And Gary estimates that Patty went 10 or 11 times on the dental mission. So please join me today in honoring Patty Hill and thanking Earl and Margaret for their nice contribution.
Thank you, Dean. It's now my great pleasure to pass the mic to our eminent Jim Hebner to introduce our special guest and speaker, Dr. Wesley Burks.
VJ Day, I may be the only one, there may be more, but I was 5 or 6. What I remember about that, it's really funny, word came, somebody ran through, people were blowing their horns, it says, the war is over, and Daddy says, come on, son. And we got in the car, we went downtown, this is a true story, and everybody in town was over town, this is Steve's Mountain, everybody was there, and it's really funny, when you're 6, all you remember, I'd never seen toilet paper being thrown around. And people were driving down the street with broomsticks, with toilet paper, just papering the town. And I was thinking, for 6 years we had waste, literally in which time toilet paper was one of the things that was being rationed. And there were also cars lined up at all the service stations because immediately you could buy gas again. Somehow or another, I didn't know very much about the Japanese war or the bomb or any of that. That was my memory of all that you triggered me. So I asked, I thought it would be interesting today because most of you know that UNC healthcare is just far and away the largest, most dominant and part of this community, employs more people and does all that. And the CEO is going to be here to talk about that today. It was a valedictory from this job where he just left, and he's going to tell you about his new job, I suspect. And didn't really have a chance to ask you where the idea came from, but you're probably going to tell us that when you talk. And so I don't know how many of you grasp the scale of the job, and that is here we think about the Rotary budget, or you think about your budget. He's presided over a $9 billion annual budget with employees of 55,000 employees, 3.5 million clinical visits, and a medical staff of about 7,000. And I thought it would be interesting thinking about how far he had come. I asked him earlier today, I said, Wesley, when is the last time you used a stethoscope? He said, well, last week. I still do rounds at the med school. And I think that speaks to the man who is capable both of hands-on, in your face, one patient at a time, and also presiding over an extraordinarily important part of this of the state of North Carolina and our community. So please give a nice, rousing welcome to the CEO, just retired, president and CEO of UNC Healthcare, Wesley Burks.
Not be able to watch TV. First, thank you for allowing me to be here with you today. I thought back as I was preparing, the last time I spoke with you was kind of on the backside of middle of COVID, and how much the world around us, and especially the world of healthcare, has changed since then. I also thought about, like, of all the different audiences I have a chance to be able to have a discussion with, y'all were the second best, most engaged. And I say that only because you really are engaged, and you ask like amazing questions. You ask questions like I never really thought, and then you have to think really hard. Nursing school is number one, always. The nursing students have
somebody.
I'm declining that phone call. Whichever computer, there's somebody called too. So what I was going to do for a few minutes is one, just talk about big picture healthcare as pertains to UNC Health and where things are in the big picture. Second thing we'll talk about is transitioning from that to the new role that I have, and then just reflect on the time as a dean and CEO. So the first thing in big picture in healthcare, with all the environmental changes nationally going on, it has a huge impact on UNC Chapel Hill, the healthcare system. The healthcare system is here, Rex, all across the state. There are 19 hospitals. As Jim said, it's like $9 billion a year, 55,000 employees in every place from here in Chapel Hill. There are 11,000, 12,000 people that come to work there every day. To Rex and Raleigh, all the way to Jacksonville and Andersonville. That's UNC Health. A third of it is rural healthcare and our ability to help them in ways that they really couldn't. People could not have survived in the local hospitals after the hurricane in the West without being part of the system. And I say that in a good sense. We all kind of came together and helped them be able to get through it. So big picture healthcare, academic healthcare systems that have teaching as part of their healthcare here in Chapel Hill particularly. Then the changes that have happened through the NIH and federal research funding in the last 6 months have had a huge impact. The clinical care part I'll talk about in a second, but there's really a two big hit part of it there. So from a research standpoint, both for Duke and UNC Chapel Hill, Duke's probably, the initial hit was about 150, ours was about 100. It's backed off of that. There's some things, our final decrease is about 40 million. Duke's will be a little bit more. And that's all people. It's people that have had to retire, go on, do something different. We can talk all day about the reasons for that, but it's really specific projects that were line item cut. That's how it got to the $40 million. So it's a huge impact on the people that do research, which is a large part of a medical school, is people that are there to do research every day to try to change people's lives next week, next year, 20 years from now. Just like the namesake here, change people's lives and his work on DNA repair. When he did it, was a big deal, but then it's become increasingly a big deal because it really changes people's lives and people understand and use the technology that this chair represents. So from a research standpoint, the people that do research, it was almost, and I won't say this to exaggerate, an existential crisis, because coming out of Washington was the message, and nationally to some degree, we don't like what you do, you're doing it wrong, and that's what it felt like. It's less so as time has gotten from the initial discussions about it, but it still somewhat feels that way. A lot of it was specific things that people didn't like in the new leadership of the NIH, FDA, CDC. Example might be the vaccines, a certain type of vaccine that we couldn't have gotten through COVID without that, then we can no longer do research in that area, which doesn't really make sense, but that's what we're dealing with. The researchers have gone from oh my gosh, what's going to happen, to now, in the last 4 months, then there's been almost a 20% increase in grant activity to try to come up with new ways to fund what they're doing. So they've responded in a way that you would hope. That's their livelihood. We want to do it. We just have to figure out a different way to do it. And it's been really cool to see them rally around each other, departments. This is microbiology, pharmacology, genetics. People that work in those areas, they're doing different things now to make sure they can still keep on doing their research. So I'll switch from that to the big picture of clinical care. So again, things that happened in Washington, the impact, the bill that was passed, other things, even this week statewide, huge financial impact. So I'd say at the beginning, healthcare costs too much. I don't think anybody or most people would not disagree with that. The difficulty is inside healthcare, you're dealt with this entity, this organization. This is the way healthcare is financed. I didn't create it, I can't change it. I can work within it. I can try to change it over here. But while you're in it, you're responsible for taking care of people, and you're responsible for the people that you work with to be able to change big picture healthcare. That's not necessarily the seat that you can do it. You can help, but you can't change healthcare within that seat. So we can talk about that later. But the way healthcare is financed is crazy. I don't think anybody, if you have a serious discussion between people with the healthcare, would go like, oh, let's make up this system and describe it as we have it right now. There's historical reasons out of World War II and insurance companies and everything. But if you'll pardon me for just a second, I'm going to use an analogy. It falls away in so many respects, but it does make a point of how healthcare is financed. So rather than work in healthcare, then what I do is work in the car business. So anybody that's in the car business, I apologize for my stupid analogy. But in the car business, to stay alive, pay my employees to provide people cars, I have to sell 100 cars a year. So that's I know the finances of it, I have to do that. But the government regulations say I have to give away 8 or 9 cars. And if Jim comes to my car dealership and says, he just walks in and says, I really need a car. And I can't turn him away. I can't say, go to Duke and get a car. I've got to give you a car. So that's the first 8 or 9 out of that 100. The next 50 are government cars. This isn't a slam on the government, but it's just the way it is. It's a Medicaid car, it's a Medicare car, it's a Medicare Plus car, a Medicare Advantage car. And I sell every one of those cars for less than it costs me to make them. So now we're up to about 60 cars that we make, we give away. We get some money back, but we can't pay the people that are making those cars because we haven't made enough money to do it. Now we have 35-ish, and these numbers are vary by place, but they're pretty consistent here to other large places like that. So now we sell 35 cars that you, the people in this room, through your insurance company, pay for. Blue Cross, Aetna, however you want to do it. You pay your premiums, you go to the hospital. The person that was just in the hospital you talked about, they pay their copay or they may not have a copay. You're paying for 100 cars. You're not paying for 35 cars. Because that payment has to help pay for everything. Those 8 cars that we gave away, somebody's got to, for that money, you can't just go to the money tree and get money for it. It has to be. And that's where the healthcare money is spread out. And that's where people talk about the transparency part, and you'll see articles about, well, a CT scan costs $1 at this place and $5,000 at this place. That's the reason. As you do the financing to pay for the 100 cars, you spread your cost out, and people do it differently. There's no book to say this is how you should spread your cost out. And then, oh, by the way, I don't really have to, I can't stay afloat in my organization with only selling 100 cars. I really have to sell 110. Because that other 10 cars helps me invest in the future of new buildings, new lines to build more cars for the next year. I can't stay afloat by just building 100 cars. So again, the analogy falls in so many different ways. I'm not in the car business. I don't equate healthcare with car business. It's taking care of people and taking care of the people that you work with. That's healthcare. But that's how healthcare financing is. And that's what you deal with every day, like the kind of vagaries, the craziness of it. But you're left with that. You can't say, well, I don't really like that. I'm not going to give away those 8 cars. Because the federal government will shut you down. Like there are laws that you can't do that. People get put in jail for trying to do that. So that's how healthcare is financed. And so what's happened in the last 6 months is the bills to reduce Medicaid, reduce the cost of Medicaid. You've already lose money on it. In the sense you can't pay for the care on what you get reimbursed for Medicaid. Now the Medicaid expansion, which our state took a decade of discussion, was one of the latter ones. Not every state in the country has expanded. Really, for North Carolina, you have access to another 700,000 people that we didn't have before. So that will go away by the bill. And then there's something called HASP, which is an acronym for the Healthcare Assurance I want to get it right so that I'm not, because we just talk about HASP all the time. It's a healthcare access and stabilization program. And the state, when they expanded Medicaid last year, HASP was part of that. And basically, it's a federal program. Again, we can talk about the good and the bad of that. But that program takes those Medicaid cards, and now we get reimbursed at the cost of your third-party payers. So that Medicaid card that we were paying to lose money, now we get reimbursed the differences from the government and the state, mostly the federal government, that then what the Medicaid card, we get reimbursed for it like we would a third-party payer. And that's where the Medicaid expansion financially made sense for all the healthcare providers across North Carolina. The Medicaid expansion gave access, but it didn't bring the dollars with the HASP access that they created when they did that. That's what brought the resources in. So to do away with all three of, do away with HASP, do away with Medicaid expansion and reduce Medicaid, then if all of that happens the way it is in the bill that won't get enacted for a couple of years, that's $850 million a year in a couple, 3 years. And so, like we talked about a $9 million budget, that's a chunk of that all across, then that's just people. So it's, again, the politics aside of it, then that's a huge change in financing, like relatively quickly. So what you'll see is all the healthcare providers, that's part of the reason you're seeing like the reductions that do, less so at UNC. UNC Health, we started a strategic plan about 30 months ago, serendipitously. We spent 15 months outlining what we want to do, talking about efficiencies, building new things, like something came out today, news about combining urgent and emergent care, like all across the triangle. That was part of the strategic plan that we've been talking about. And we started about 9 months ago the execution of that strategic plan, again, serendipitously, and that will allow us at least the first couple of $100 million to weather that storm, because those are the savings that would have happened out of that strategic plan. The biggest impact in North Carolina will be on the rural hospitals. So North Carolina has second most to Texas, the number of people living in rural areas. It's about 3.5 million out of almost 11 million people. And most of even the hospitals like with us that are part of UNC Health, their finances are tenuous at best. And with HASP and Medicaid expansion, it made it that they could stay open more than another couple of years. But if those go away, it will have an impact. And will help here in Chapel Hill and Rex to make sure that they're not, that has impact lessens, but it's still going to have an impact. And the biggest impact on all that bill that I talked about is in rural health care, by far. Really? It's not going to be on y'all that live here in the Triangle, or if you live in Durham or Charlotte. It's really going to be on rural health care. It's a major hit there. So, it's enough of the depressing news about it. Like, you can see why I'm retired. But at the same time, the healthcare really, at the end of the day, it's about two people. It's about taking care of patients, and it's about taking care of each other. Those 55,000 people I had the opportunity to work with. And once you stay there, then the other thing is noise, and it's frustrating, and it's like, that once you like really talk about what you're doing around that person that you want to take care of, people that you're already taking care of, or new people that you can take care of, and then you focus on the people that you work with, then it's a great place. It's unbelievable. I mean, I feel fortunate that I've been able to be in that area for 40 years. That I've done different things. I never expected, even a decade ago, to do this role for the last part of my career, but it was like an amazing opportunity. It's the best job I ever had by far, but it was by far the hardest job I've ever had. And so I'm glad that Christy's doing it now, so it's good. So as Jim said, I stepped down, I retired from that job 1st of July. The way that UNC Health is put together is the school and the healthcare system are put together by the position. Christy Page is the interim. She's a family medicine doctor from Wilmington. It's lifelong Tar Heel, and it's great. And I hope that she's the interim now, and I hope that she'll walk into it, because she'll do a great job. She has a heart for those two people, the people that we take care of, particularly in rural areas, and a heart for the people that we work with. So leaving that aside, for me, the next step has been to take a few days off and then work on the new Children's Hospital project. Some of you may have heard, may not have heard, but we have literally the people that take care of kids in the Triangle for 50 years have talked about a dream of having a freestanding children's hospital in the Triangle. The state does not have one. All the children's hospitals are hospitals within a hospital. So pediatrics at UNC is called UNC Children's. It's 15% of the big hospital. Same thing at Duke, same thing at Atrium, any place else, Wake Forest. So it's a hospital within a hospital, but 85% of the system is not children.
Right.
And so I've been in a position, like we couldn't prioritize some of the things that are there, even from the investments all the way to third-party reimbursement. When that happens, children get the short end of it. People in healthcare acknowledge it. As a pediatrician, I know that. It's been there for a long time. But once you go to a freestanding children's hospital, the care changes and the finance drastically change, because it's all about kids and adolescents. So again, people for a long time have said, have you thought about Duke and UNC coming together to have a freestanding children's hospital? So it's been a dream of lots of people that have taken care of kids here for a long time. It just happened that I came along, and the person who's in the same position as Duke is a pediatric surgeon, and we were able to get the state interested in making an initial investment, and that's why it's started to come together. So we signed, after about 15 months of discussion with Duke, we signed an agreement with them in January. So all of their services that take care of children and adolescents less than 18, pediatrics, ped surgery, urology, everything's coming out to go to the new hospital. Same thing at UNC. Everything related to kids less than 18 is going to go to the new hospital. So together we're going to build a 500-bed children's hospital. That's the equivalent of Cincinnati Children's Hospital, Philadelphia, Boston Children's. We will build a 100-bed mental health facility that the state hugely needs, and has for a long time, and the needs are increasing. And all the things that go with it, research buildings, physician office buildings, all the things like that. So that's the announcement we made in January. Recently we made an announcement that we've identified the land. It will be at the intersection of 540 and 1, which is like kind of South Apex. We bought 230 acres. We're in the process of it. It's pine trees and 3 old tobacco barns right now. So it's like new land that we can do with. We have lots of renderings to put in what I just described as far as the hospital and mental health facility and other things like that. Design firms, we have the RFA out for that now. The physicians from both places are working together, groups of them, to try to say, how do we think this? How do we build a children's hospital? It's not been done like this ever, in that you're taking two really good academic places, taking things away from the parents. You're having a new child, and that child is going to grow up. They will still have parents, but they are going to be free and clear. It's not Duke or UNC controlling it. They'll be on the board, but it's really a freestanding, independent children's hospital. That's what we're describing. That's what the state doesn't have. The closest one to what I'm describing right now is National and Children's, DC Children's. It's 2/3 the size I just described. Atlanta, 20 years ago, had 5 small children's hospitals, hospital. They came together. Now there's a children's hospital in Atlanta. This will be a little bit actually bigger than that. So there's really nothing else from here to Miami to DC. So the top children's hospitals in the country are Children's Hospital of Philadelphia, Children's Hospital of Boston, Cincinnati Children's Nationwide, which is in Columbus, maybe Lurie Children's Hospital in Chicago. The size and what we'll bring together will put it in that ballpark right away. What it does for care is it sets up a primary care network that will help people in rural areas have access to things. You can do things there at home, with the support of this entity you couldn't do before, but it also provides that tertiary quaternary care a place to go. Right now, North Carolina is the leading state that sends kids out of state to get care. Like the people that fly planes to do that, like we leave the country doing that because we don't have these facilities. So concretely what this means is that, so there's pediatric cardiologists at UNC, there are 15 of them, and they have to cover A to Z. So there's one person in ultrasound, there's two people in intervention. At Duke, there's 20-some pediatric cardiologists, same thing. They have to cover A to Z because they're by themselves. Now we have 50 pediatric cardiologists that are working together, and we have 6 people that are doing intervention, and we have 5 people in ultrasound, and the expertise you get in what I just described is huge. So you don't need to go to Cincinnati Children's. It's a great place, but they need to stay here. You don't need to go to Boston to get that specialized quaternary care that you may only see 10 of a year, but we have the expertise here to be able to do that. And so not only for the care for kids, it will keep them here, it will help all the surrounding hospitals, but it also, it will help us bring in students, in particular residents in training, because they want to train at a place like this. If you're a pediatrician, I trained at a children's hospital. Craig Albanese, the person at Duke, he trained in a children's hospital. Or once you've been there, when you've walked into a children's hospital, you take care of kids, you know it's the right place. And not that we don't do it well here now, or not that they don't do it well, but we're in adult hospitals. And for a child, then this is like thinking of a specialized care that you might go to a heart place for adults, like all the special care. This is what this is for kids. So I could talk for like hours, obviously. We have about 20 people full-time working on the project. I hope the mental health facility would open 31. But it's a long time project because of the complexity of what's being built. In that 500-bed children's hospital, 60+% of them are really, really specialized places. The neonatal intensive care unit, the pediatric intensive care unit, the step-down units, and it's not like building an adult hospital that you build around. And that takes a long time. Like the new surgical building that we opened that some of you may have been in already, that was 5 years in building it, not just the planning of it. And so you can imagine that complexity compared to the children's hospital. So hopefully you have heard some, hopefully this will encourage you to read more about it and learn more about it. If you want me to come talk to wherever, whomever, I'm there. Like, I'm excited about doing this. It's an amazing opportunity for the state to take care of the kids. We have had an investment from the state legislators and really help jumpstart this. It's about a $3.5 billion project. So it's not a small undertaking, but financially, we'll figure it out, we can get there. So I'm going to switch, the last thing, time-wise, because I know you'll have plenty of thoughts and discussions. So Jim had asked me to reflect on the time of my old job and what I learned. And this is like nothing I want to say, like most of you don't know this already. So I'm not saying it like I'm like the first one that figured this out at all. So it took a lot of, I started just before COVID. So the world I thought I was walking into changed drastically, obviously. The world around us, the world of healthcare, you know, in 3 days we went from almost 1,000 people in the hospital to like less than 400. What people did, how we worked together, like all that changed, and it kind of varied off and on. But the first 4 years were like pretty chaotic because of like COVID and the aftermath and different waves of them. So I'm not sure what like a normal dean CEO's job would have been like if I ever really had that. But it was an amazing one. Like as I said before, wasn't something I anticipated doing. I'm glad that I had the opportunity at the time that I did. I learned over time that I just had to be myself. I'm like a big time introvert. I can talk only with a lot of preparation. And that's okay, but that's me. I can do a video and talk, but like I've got to have like seen it for several days before I'm going to do the video, and then I'm okay talking, but I'm not going to be spontaneous because I'm not an extrovert. And And that's the person I have to be. And so the genuineness of as best I can, just to be the person I am, and then that's the first thing. Second thing is the role that this is, and for many of you in the positions that you have or you still have as leading an organization. As the head of that, you hold a vision, and then you talk to the people that you work with, so they know you care for them. And you can't skip over like the bad part. But you can't have the bad part most of what you're telling them. You acknowledge the difficulties. They're there, like we just got Casey Mann in research. But then you have to give them hope, legitimate hope, without blowing smoke, without like falsely doing that. That's your job. If you can't give them hope, then you don't need to be doing the job. That's what I thought. So, one, be yourself. Two, like you lead with the vision. And you have to acknowledge the difficulties that are there, but it's not most of what you're trying to tell people. And then the third thing is the people that you hire are the most important thing you can do, because that's who you work with, that's who you leave behind. As I was finishing the last 4 or 5 months, different people asked me just different questions about decisions that were made, and honestly, in 7 years, I made less than 5 decisions, and I probably could take a couple of fingers away. Because if you think about it, I may influence to have a discussion, but I'm not making the decision, or the people I'm working with and my support of them has failed. Like if they have to come to this position, or 2 people are fighting, then that's a failure of us working together. That's the way I feel. So hiring people that, like that's their job. Like what do you recommend? What do you want to do? They're making the decision. They should be making the decision. If there's disagreement, you get them to talk together. They're not making you make that. So the decisions I made, like I said, less than 5 of them legitimately. One would have been, we have to have everybody vaccinated. Nobody else could do that. Nobody else could say that. That happened. That happened literally within 12 hours. An opportunity came. By the next morning, we'd done it. The people I work with couldn't have done that if they didn't. That wasn't like the big picture, but the chief clinical officer, they have roles. And most of the things clinically are related to them, like what I just described, the urgent care, the emergency rooms, urgent care buildings built together that really are better ways to take care of people, so that not everybody's going to the emergency room, or you don't have to go 2 different places. That our chief clinical officer and our strategy people, they made that decision. They tell me about it, we talk about it, I'm encouraging them. How many of you know about our hospital at home? Okay, anybody who's been in a hospital at home? Did you like it?
I did. Great.
I'm doing that if I get sick. If you go to the emergency room and almost everything short of intensive care, you can go home, we'll bring the hospital to you, you get monitored 24 hours a day, you have people come visit you, you got your own clicker, you got your own food. The outcomes are the same. So we have 25, 30 people right now every day that are in the hospital at home. Needs to be more. Most people, like when you go, you probably, most don't know about it. And you should be offered the opportunity. But it's an amazing thing. People that I work with made that decision. I encourage them. I said, like, that's the right thing, because I hope that's what the future is. Because we need, like, the costs are less for everybody if you do that. By staying home. So, anyway, the role of finding the best people in each of those areas is the biggest role I could do. I leave and they're still there. They're still doing their things. It shouldn't be the person leading making those decisions, because then it, like on the chief clinical officer, if I'm making the clinical decisions, what's his role? Or if I'm talking about like external affairs, if she's not making the decision, why does she want to do the job? Like, your job is to help find the right person that fits culturally, that can make those decisions. You can talk about it with them, you can support them, you can encourage them, you can influence them, but you want them to be doing that. So I learned that like 1,000 times over. So, yeah, I'm ready to go to the questions. I've got my Kevlar on. So I'll start here and then there and then not here. So go ahead.
Can you tell us a little bit more about the couple $1 billion we're talking about for this children's hospital? I mean, obviously we know about the budgetary process and microphone.
Yeah, so I can hear, and I'll repeat the question, was about the 3 $2.4 billion it costs to build a children's hospital. About 1.8, 1.9 of that is a 500 patient bell tower, another 500,000 is a mental health facility, so it's broken down by each of those pieces. The budget right now is, we have an initial investment from the state of about $320 million, which is nice, but it's not the chunk of it. And so we're fundraising, once the hospital opens, at least $1 billion to $1.5 billion you can finance, because the financial return to the hospital, how it works, pay that back pretty easily. So we need it in the ballpark of $1 billion from all different ways, to be able to legitimately make it work right now.
And the horizon for that would be?
Ideally, that we've got 500 million that will last toward 3 years. So there's a middle part before the hospital opens that we've got a dip, and that's why we're out raising funds.
Okay, if you have a question, we've got microphones here that way. We'll call on you that way.
Okay.
Okay.
You go.
Okay. I want to know if you're gonna have outpatient and inpatient rehab.
Rehab.
Therapy.
Yes.
Sorry.
We'll have physical therapy and pediatric rehab. Both of them.
Also for the outpatient?
Yes.
Oh.
Yeah, it's a big part of taking care of kids. Yes, ma'am.
Can you explain more about hospitals at home, which patients are eligible for, what types of cases?
So the diagnosis that we have, there are about 30 of them, from pneumonia to hypertension, whatever. Really, almost, by far and away, the most common reasons to be hospitalized for us as a group in here, short of like a step-down unit or intensive care, then you can be at home. You can be on oxygen, you can get IV antibiotics, you can get, somebody's coming to see you all the time, you're constantly, there are monitors around you, there are people in the Blue Cross Blue Shield old spaceship building. That bottom floor is NASA headquarters. So you go in there and there are people there all the time. There are nurses, physicians talking to you, people coming by to see you. For most people, I think his experience has been very, very positive. The bounce back rate, in healthcare, you talk about a 30-day readmission rate. The 30-day readmission rate for that group of people in hospital home is less than being in the hospital. Yes, back here. He was next.
Thank you for your comprehensive overview of the healthcare ecosystem, very efficient overview. I have two questions I'm going to allow you to choose to answer, one or both. My first is, if you go back to your initial description of the diminution, the acute diminution of funding, NIH funding to many of the swim lanes within the space of research. And of course, we appreciate the devastating impact it has on the junior investigators and, starting career kinds of individuals. But can you speak through your lens what you think the long-term impact that will have just on our country's leadership and research in the healthcare space because of these acute impacts? And the second question I have is with respect to the complex matrix of healthcare economics. Where do you see us figuring out how to sustain it if it is changing the scope of work of some of the things that we do now and reallocating those tasks, or what is the implication of introducing technologies or artificial intelligence? And really, we're sort of playing three-part Monty with respect to distribution of home care and all the other things, but long term, how do we sustain healthcare in this country economically?
The first one I can try to talk about. The second one is obviously. So on the first one, as you said in your question, the impact on those that have been in this area doing research less than 10, 15 years is huge, because it makes them feel, may not be what's being said, but what it makes them feel is that what you do is not important. So we can, there are two parts of the cuts. One were the infrastructure cuts, And I understand those, but the draconian change that quickly is why it's such a big impact. So you listen to people talk about indirect costs, which is what it costs to do research. It was a crazy system that was set up that was paid separately to each institution rather than by each grant. Should have been on the grants, but it wasn't. But the difference is, like, the indirect costs at Chapel Hill were 50-some%. They were another 15% in Durham, and they're 7 miles away. Like, that didn't make sense, but that's the way it was. That's the game that was there. That's what was getting cut down to initially 15%. So that's where all that cut, and then what happened was the individual grants were targeted, saying you can't do A, you can't do M, you can't do Z, those got taken away. That's where the younger investigators, like, so they're, like, my livelihood, people are not prioritizing, it doesn't really feel good. Many of them are rebounded to do research in other areas, but it will have an impact if it stays this way for a long term. My hope is, maybe naively, that it's gonna turn. This can't be forever. And we'll get back to where that science and those investigations have some value, and we're not gonna lose generations. We may lose one generation, but my hope is that we won't lose generations. Second question, from a healthcare standpoint, I don't know the right answer. You look around the world, Canada is different than the UK, is different than Germany. Nobody has the right answer that I can tell. Certainly in the third-party space, then that's taking care of the people that are well for the most part. And that, those paying for those cars, that way you have to pay for everything else, and that doesn't really make sense, because now y'all are paying for everything else. The reforms in Medicaid need to happen. There's things that are there that can be better, but it has to be coordinated, all that together. And right now it's definitely one-offs for different things. So, like the bill out of Washington, what I said has a $850 million a year impact on UNC Health. That's separate than what Blue Cross is talking about doing, and it's separate than what Department of Health and Human Services are doing. This part I'm less optimistic about, because it's got to be a political discussion, and it's so difficult to do right now that I'm not sure how to come out of it. Yes.
Yes, thank you. Kind of an addition to what Saul was asking. Are you right now being handcuffed? Are you being told by the government what you can and cannot do research on? For example, can the university do research on vaccinations if they want to? Whether it's from a grant the university is being given from the government or internal research you have. Are they dictating what you can and can't do?
So there are limitations on what federal government funding will come forward. It's NIH, VA, Army, whatever. And so like the last one was the mRNA vaccine. They will not pay for research. It does not mean we can't get a company or a foundation to pay for doing that. It doesn't mean that right now. It just means they're not going to do it. There is some like research in the broad area of diversity, equity, and inclusion. That's been a big target. That's not true what I just said about mRNA vaccines. Like if we got funding from over here to do that, that's going to penalize us. So that's more broad, and it's mandated that you can't do certain things. That's where a lot of that research cuts were related to looking at different areas in healthcare. Like there are a lot of healthcare disparities between urban and rural, and even in urban there's differences, and even in rural there are differences. You can't explicitly, in the DEI terms, do that, and you can't get funding over here to do that.
How do you set your priorities then?
The priorities are two people, the person we're going to take care of and how best to do that, and it's different if you live in Rockingham or Raleigh. We have to address it, and how do we take care of the person in Rockingham? We're going to use technology. We're going to use all kinds of things that are different than that person in Raleigh, because we have a place they can go. Rockingham, we don't. We can't get doctors, nurses here. So we want to take care of them, have the same end result, but we just have to do it differently. Yes, sir.
Stand up, Jim.
Well, I can hear okay.
Yeah. We've got a short.
I understand.
Short, quick question.
I understand that planes are not people, but they do suffer from infant mortality, and they go through a long life, and then wear out at the end. And more to the point, the doctors who take care of planes are very human, just like medical doctors.
Yeah.
In the commercial airplane business, we pay for outcomes. We don't pay fee for service. We specify very little in the rules. We get, we think, pretty good outcomes. In the military business, we pay fee for service. We pay for everything you do. We tell you a lot about how to do everything. And we get really crummy outputs. Would you please comment on the effect of fee for service versus paying for outcomes, how it is in other countries, and how we might do better?
So it's a really, really good question. It speaks to the heart of where we need to be from a healthcare standpoint. There's a broad term called value-based care, which basically, rather than taking care of a person in fee-for-service like this, is you now are my group, and I'm going to take care of y'all the best I can. I'm going to take care of you as an individual, but I'm going to take care of the whole group. By doing that, and the reimbursement is based on what I just described, then you can see the person that you need to see that has the license to take care of you. You can go directly to the physical therapist. You don't need to go to the doctor first, go to the physical therapist. The whole system, or most of the system right now, is driven on finances of fee for service. And that reform, particularly in the third-party space, is a huge deal to get to value-based care. Like, we've done value-based care for 15 years. We do it really well. It's less for the patient. It's less for us. There's 10 to 20 million each year that are saved that can be reinvested someplace else. It's by far, I'd rather live in that system personally. I'd rather be able to, like, if I need to have education for my diabetes, then I have the right person come. I don't need to go to the doctor to see that. Right now, it's the system drives you, the healthcare system drives you to have to do that because you can't pay for those others because your money comes out of that fee for service.
Thank you for coming. See you next week at the Teacher Supply Store. Have a nice weekend.